Jesica Santillan. On February 7, 2003, 17-year-old Jesica Santillan was wheeled into an operating room at Duke University Hospital for the transplant that was supposed to save her life. She had a severe heart condition and lung damage. Her family had crossed the border years earlier so she could get care. That day, surgeons prepared to give her a new heart and lungs from a donor. The atmosphere was tense but hopeful. The operation was long, complex, but technically smooth. What no one stopped in time was something shockingly basic. The blood types did not match. Jesica was type O. The donor organs were type A. That error, a simple compatibility check that should have been absolute, slipped through communication between the transplant team and organ procurement system. The mismatch was not caught until the surgery was nearly complete. In the days that followed, Jesica's body treated the organs as enemies. Inside her chest, rejection hit hard. Fluids built up. Her heart struggled. She swelled, slipped in and out of awareness, and needed machines to breathe and pump blood. The pain was not just one sharp moment. It was a drawn-out assault on every system as her body tried to fight what had been sewn into it. Doctors attempted powerful drugs. 2 weeks later, they tried a second transplant with correctly matched organs. It was too late. On February 22nd, Jesica died. The cause was not a rare unknown condition or the natural risk of a brave attempt. It was a preventable clerical and verification failure at the most basic level of transplant medicine. A never event that turned the surgery meant to save her into the direct source of her suffering and death. Rhode Island Hospital. On July 30th, 2007, an 86-year-old man was taken into surgery at Rhode Island Hospital for an emergency procedure to remove bleeding from his brain. Scans showed which side needed relief. He was prepped, marked, draped, and anesthetized. The team moved quickly. Somewhere between imaging, notes, and checks, one step broke. The correct side was not clearly confirmed. The surgeon opened the wrong side of his skull. The bone flap came off. Brain tissue was exposed. Time and focus went into exploring an area that was never the problem. The real clot remained untouched on the opposite side, still pressing into healthy tissue. When the error was discovered, damage was already done. The man woke, if he woke fully at all, not improved, but worse. He developed complications, swelling, and decline. 3 weeks later, he died. For this patient, the pain and harm were layered. First came the original bleed, then the trauma of an invasive brain surgery on healthy tissue, headache, confusion, weakness, and the crushing reality that the wrong side of his head had been opened. This was not a complex mystery of medicine. It was the failure to stop before knife to skin and say, together, this side, confirmed. In neurosurgery, that pause is the line between help and irreversible injury. That day, it did not happen. Heartland Regional. On September 2, 2009, a 65-year-old woman entered an operating room at Heartland Regional Medical Center in Marion, Illinois, for surgery described publicly only as involving a suspected bone issue. She was anesthetized, draped, and prepped with flammable antiseptic. Supplemental oxygen was in use. An electrocautery tool and a heated sparking device was part of the setup. These things together are safe only when the team treats fire risk as real. During the procedure, a flash fire erupted. Drapes and exposed prep solution ignited. In an instant, her upper body was caught in flame. Face, neck, chest. Staff put the fire out quickly, but burns that happen in seconds can destroy skin, airway, and deeper tissue. She was transferred to intensive care, intubated, heavily sedated, her body trying to recover from both surgery and severe thermal injury. 6 days later, on September 8th, she died of the wounds and complications. Even sedated burn care is not painless. Repeated dressing changes, procedures, infections, fluid shifts, and the body's own stress response. For a patient who went in expecting a controlled surgery, the reality became catastrophic. The mistake was not a freak lightning strike. It was the basic failure to manage oxygen, flammable prep, and cautery in a tight space. A textbook never event that turned the sterile room into a fire scene focused on the only person who could not move away. Jeffrey Fulcher. On June 15, 2022, 58-year-old Jeffrey Allen Fulcher went into surgery at the Medical University of South Carolina to remove part of his esophagus after treatment for cancer. It was meant to be a careful, minimally invasive procedure. Instruments were counted. Retractors were used to hold tissue aside. At some point, a metal Thompson retractor blade ended up inside his abdominal cavity. It was not found before the team closed. The final count was incorrectly recorded as complete. In the days that followed, Fulcher told staff he was in severe abdominal pain. Notes described him as doing well. The blade was still inside him. As hours passed, the sharp metal edge damaged his bowel, letting bacteria spill into his abdomen. Infection took hold. His heart rate climbed. His belly swelled and hardened. Only later imaging showed a large volume of free air, a red flag for perforation. Even then, action lagged. By the time surgeons went back in, they found dead colon and widespread infection. Segments were removed. His condition spiraled into full septic shock. On June 21, 2022, Jeffrey Fulcher died. His death certificate listed sepsis, peritonitis, bowel perforation, and a retained surgical instrument from the first operation. The pain he endured is easy to imagine and hard to excuse. Days of increasing agony from a foreign object that should never have been left behind. Infection burning through his abdomen while he repeatedly said something was wrong. All because one piece of metal was not seen, not counted, and not checked again before the incision was closed. John Michael Murdoch. On December 2022, as described in later lawsuits, 52-year-old cancer patient John Michael Murdoch lay on an operating table at Oregon Health and Science University for a tracheostomy, a surgically created hole in his windpipe. This hole allows air to pass into the windpipe to help him breathe. He was reportedly awake and conscious. His face and neck were cleaned with isopropyl alcohol. Oxygen flowed near his airway. An electrosurgical tool known to spark was brought to the field. Standard safety calls for letting the alcohol fully dry and managing oxygen carefully. According to the complaint, that did not happen. When the tool was activated, a spark met wet alcohol and oxygen. A sudden flash ignited his face. Murdoch's skin burned while he was still aware. The pain of a facial burn at close range is extreme. Heat, flame, the smell of burning hair and flesh, and no way to move as staff scrambled to put it out. He survived the immediate event but was left with severe burns and disfigurement. His family says he never fully recovered from the trauma and injuries. He died about 6 months later in June 2023 while still dealing with the damage and his underlying cancer. Litigation now debates exactly how much the fire contributed to his death, but there is no dispute that it never should have happened. A surgical fire like this is not a complex failure. It is the direct result of skipping simple precautions. Let alcohol prep dry, control oxygen, announce when cautery is used. Those steps are basic. When they are missed, the person on the table is the one who pays, sometimes with months of pain before the end.